Welcome back to the Deep Dive. We're here to get you up to speed on complex topics, make it stick, maybe even make it a bit interesting. Today we're tackling something really vital if you're an orthopedic resident, especially with those big postgraduate exams looming. Total hip replacement instability. THR instability. Okay, let's unpack this. Our goal today is to pull out the absolute must-know stuff from a great set of notes on THR instability and dual mobility. We know you need this info efficiently, but also thoroughly. This deep dive is actually based on the Ortho-Made Simple notes you can find over at mokyingren.sg. They were put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital in Singapore, and he finished his FRCS back in 2022. Just brilliant notes.
Yeah, they really are. And what's fascinating here is just how complex and honestly, how clinically relevant THR instability is. Getting your head around these details, it's not just about exams, it's fundamental for good patient outcomes. We're talking about preventing a really frustrating complication.
Absolutely. So let's start right at the beginning. The foundation. Ideal implant positioning. The aim is always to get that implant's primary arc range, its main movement window, smack bang in the patient's functional range of motion.
Right, and the classic reference point is Lewinek's safe zones from, 1978.
Yeah, that's the one. Cup inclination 40 degrees plus or minus 10, anteversion 15 degrees plus or minus 10, and the stem anteversion 15 degrees or more. Sounds neat.
It sounds like a formula, doesn't it? But
Exactly.
yeah.
But here's the kicker. Just hitting those safe zones, while it isn't foolproof, dislocations still happen, even with implants seemingly perfectly placed by those numbers.
Which really pushed people to think differently. Like Dorr and his group in 2009 looking at things like combined anteversion.
Right, targeting 35 degrees plus or minus 10.
Yeah.
But then how do you even, check that during surgery if you don't have navigation?
Well, there's the Ranawat sign. It's an intraoperative assessment.
Can you walk us through that?
Sure. So the patient's in the lateral position, hips stabilized. You take the operated leg, extend it, and then you slowly internally rotate it from a neutral foot position. You keep going until the base of the femoral head looks parallel to the acetabular component face. That angle, that's your estimated combined anteversion.
Okay, useful, even if maybe not perfectly precise.
Exactly. But this raises an important question, doesn't it? If the safe zones aren't totally safe, what are the real risk factors driving THR dislocation?
Good point. What should we be looking out for?
Well, you can kind of group them. First, patient-related factors, things like if the THR was for a femoral neck fracture that carries a higher risk inherently.
Yeah.
Also, prior spine fusion, that's a big one we'll come back to. Neuromuscular conditions, alcoholism, certain spinopelvic issues, even a high ASA score, meaning more comorbidities.
Okay, so patient factors, what else?
Then you've got implant-related factors, like a smaller head diameter, using a skirt on the head sometimes, or maybe a lipped liner if it's not ideally positioned.
Makes sense. And the surgeon's role?
Absolutely crucial. Surgeon-related factors. The approach matters. A posterior approach, for instance, really demands meticulous soft tissue repair, even if the big registry data, like the NJR, shows no overall difference in rates. Other things are malpositioning the components, obviously, not clearing out osteophytes that can impinge, failing to restore the proper offset, or maybe a non-union of the greater trochanter if it was fractured, leading to poor soft tissue tension.
You mentioned prior spine fusion being a big risk factor. Here's where it gets really interesting, that whole hip THR spine fusion first debate. There was that Malkani study in 2019.
Right.
It showed spine fusion before THR, even years before, led to a 50% higher dislocation risk.
Yeah, quite striking. And Buckland et al. In 2017 found similar things. THA after spinal fusion. The risk just climbed with more fusion levels.
The numbers were what? Control at 1.55%, then 2.96% for 1-2 levels, and up to 4.12% for 3-7 levels fused.
That's right, significantly higher. Whereas THR before fusion seemed to carry less risk.
So why? What's the biomechanics behind that? How does a stiff spine mess with the hip?
It's fundamentally about pelvic mobility, or lack thereof. See, normally when you go from standing to sitting, your lumbar spine flexes, losing some lordosis, and crucially, your pelvis tilts posteriorly. That posterior tilt accommodates the femur flexing up. But if you have a fused spinopelvic junction, the pelvis basically can't move. It's fixed in space relative to the spine.
Ah, I see. So the cup is fixed too.
Exactly. The acetabular cup becomes rigidly oriented. So as the femur flexes, it can impinge anteriorly against the cup or pelvis much earlier.
And lever the head out posteriorly.
Precisely. That's the mechanism.
Okay, that makes a lot of sense biomechanically. It really highlights the interplay between spine and hip.
It absolutely does. which naturally leads us back to the implant itself. How can we design implants to try and counteract some of these instability risks?
Right. If we connect this to the bigger picture, what implant factors boost stability?
Well, head diameter is probably the most obvious one. It directly influences a few things. First, the primary arc range, that's your motion before impingement, basically set by the head-neck ratio. Second, the lever range, or jump distance, how far the head has to travel sideways to dislocate, proportional to the head radius. And third, the excursion distance, which is just the head radius itself, the distance it has to pop out. Bigger head, bigger jump distance, more stable, generally speaking.
And the head-neck ratio itself, not just head size.
Correct. The head-neck ratio is key. It's affected by head size, yes, but also the femoral neck shape. A trapezoidal neck geometry, for example, gives a better ratio. And using a skirt sometimes helps extend the neck length if you need more than a standard plus head can offer. And of course, getting the offset right is critical too.
So those help stability. What about features that increase impingement risk?
Good question. Things like the chamfer geometry on the rim of the PE liner can matter. An extended rim hooded liner, if it's put in the wrong orientation, can cause problems. A cup that's too horizontal or too closed, meaning low inclination or low anteversion. And as we mentioned, not removing those impinging acetabular osteophytes. All potential culprits.
Okay, remember everyone, this detailed breakdown comes courtesy of the Orthomed Simple Notes at mokyingren.sg. Really valuable stuff for your revision. So, what does this all mean in the moment? A THR dislocates. What's the acute management playbook?
First off, ATLS principles. Rule out other injuries, make sure the patient's stable.
Standard trauma approach.
Then, usually, closed reduction. The Alice maneuver is common, done under sedation.
And if that doesn't work?
Then it's off to the operating theater. Reduction under GA, maybe with paralysis to help relax the muscles.
Okay, reduction achieved. What next?
Post-reduction, you'll want some temporary immobilization, maybe an abduction pillow or a knee immobilizer, just to protect it initially.
And then the workup begins.
Absolutely. You need to assess why it happened. Look for those risk factors we discussed. Rule out infection history, bloods like FBCs, CRP, ESR. Definitely review the op notes. What approach was used? Did they repair the capsule? Was an elevated rim liner used? Check interval x-rays for any signs of osteolysis or PE wear, like superior migration.
And the patient story is key too, right?
Crucial. Is this the first time? Or is it recurrent? Was there a symptom-free period? What was the mechanism? High energy, low energy? What if you just cannot get it reduced closed, even in theater?
Right. Key point here. Don't immediately rush to open reduction. Stop. Investigate further. Get advanced imaging, like a CT. Really double down on ruling out infection or some kind of mechanical block.
Okay. Now, let's say it's a first-time dislocation. What's the typical path?
For a first-timer, management is often conservative initially. Maybe abduction, bracing for a period. And you definitely address any obvious fixable cause, like if there's a greater trochanter or non-union, you'd fix that.
And how successful is that conservative approach? Actually, surprisingly successful for first-time events. Maybe up to 2/3 of patients might not dislocate again and won't need surgical revision.
Wow, 2/3.
Yeah, there's an old paper, Fraser, back in '81, looked at a large series. Incidence was low, about 0.6%, but of those who did dislocate, only about 17% actually went on to dislocate again and need a revision. So conservative management is definitely worth trying first time around.
Okay, but what if it does happen again? Recurrent dislocation.
Ah, now the game changes. What's fascinating here is the investigation really ramps up for recurrent cases. A CT scan becomes pretty much essential. And you need specific protocols, make sure the cuts go down to the distal femur so you can reference the intercondylar axis properly.
To measure everything accurately.
Exactly. You need precise measurements of the acetabular component inclination, anteversion, and the femoral components, anteversion and offset. You're hunting for the biomechanical error.
And the surgical principles if you do revise.
It's all about correcting the problem you found. Address the biomechanics. Correct the alignment of the femur, the acetabulum. Get the soft tissue tension right. That might involve fixing a GT fracture or even doing a GT advancement, removing any impinging bone, correcting the offset, whatever the issue is.
What about implant choices during that revision?
Several options. You could go for a standard hemispherical cup, but use a larger head size. That increases the head-neck ratio, improves the jump distance, boosts stability. Or you might strongly consider dual mobility cups, also called tripolar or MDM. These are really good options, especially if there's a history of spine fusion or it's already a recurrent dislocator.
How do they work again?
We'll get into the specifics more, but essentially the femoral head moves inside a PE liner, and that PE liner also moves inside the metal shell. 2 articulation points. It gives you a much larger effective head size, greater range of motion before impingement, and thus more stability. Plus, the inner articulation often uses a smaller head, which might have wear advantages.
You mentioned an award.
Ah, yes, the 2017 Hip Society Otto Frank Award paper. It compared dual mobility to large 40-millimeter conventional heads and found dual mobility had a lower risks of dislocation, revision, and reoperation. Pretty compelling.
Any other options?
Well, there's the constrained cup. Here, the head is physically locked into the cup liner. Massive stability, but
Big downsides.
yeah, the high constraint leads to increased wear, and there are specific failure modes like the locking ring breaking, so it's used very rarely.
When would you use it then? It seems extreme.
Really specific, difficult situations, like maybe after radiation for cancer where the abductor muscles just don't work, or after taking down a previous hip fusion where, again, the abductors are often compromised, situations where you need maximum mechanical stability because the soft tissues aren't providing any.
Miller's course usually summarizes the options, right?
Typically, 1, try to solve it with a larger head, maybe 36 millimeters or more, in a standard cup. 2, consider dual mobility. 3, constrain liner as a last resort in those very specific cases.
Okay, let's unpack this revision scenario further. Revising a hip for recurrent dislocation sounds challenging.
It is. It requires meticulous preoperative planning. Templating is absolutely essential. You need to anticipate what you might find and have all the potential gear ready. Backup options.
And intraoperatively.
Often requires an extensile approach, like a posterior approach extended distally or proximally as needed. Then it's about executing the plan. Correcting alignment, replacing components as planned.
Post-op care.
Generally follows standard THR protocols, but probably with more caution, maybe stricter precautions initially, depending on the revision specifics.
What if even revision fails or is impossible? Are there salvage options?
Yes, though they're not ideal. You could consider converting to a bipolar hemiarthroplasty. That maximizes the head-neck ratio, but you risk things like groin pain and the bipolar migrating medially over time.
And the ultimate salvage.
The girdle stone procedure. Excision arthroplasty. Removing the implants altogether. It relieves pain and infection, but leaves the patient with a flail, shortened leg. Definitely a last resort.
You mentioned bipolar hemiarthroplasty. Is a dislocated bipolar worse to deal with than a dislocated THR?
Generally, yes, the outcomes of non-operative treatment are much poorer. That Gill paper showed closed reduction only worked first time in about 16% of dislocated bipolars.
Wow, only 16%.
Yeah, and they tend to dislocate early 70% in the first month, almost all within 3 months. And redislocation is common if you do get it reduced closed. Open reduction was needed more often.
Any specific risk factors for bipolar dislocation?
The paper mentioned things like a smaller center edge angle, less than about 45 degrees or shallower acetabulum, less than around 19 millimeters deep, anatomic factors.
Okay, shifting gears slightly. What if you have an unstable hip and infection? PJI.
Right, paraprosthetic joint infection. You absolutely have to treat the infection first and foremost. The approach really depends on the patient, their health, the organism.
What are the options?
You could do a single-stage revision. That means removing everything. Aggressive debridement, changing all instruments, then putting in new components, often considering dual mobility for stability, or, more commonly perhaps, a 2-stage revision. Remove everything. Place an antibiotic spacer, treat with IV antibiotics, then go back later for the definitive reimplantation.
Salvage options if those fail.
Again, girdle stone is an option. Sometimes people ream the native acetabulum and put in a new bipolar. Or convert to a THR if possible, again, maybe dual mobility.
What about instability just from wear, like an eccentric liner wear, but the components seem well fixed and positioned?
If the components are truly well aligned, you might get away with just a liner exchange. But if the alignment is questionable or frankly poor, that eccentric wear is probably a symptom of the malposition causing edge loading. In that case, you'd likely need a full revision THR to correct the underlying alignment problem.
Here's where it gets really interesting. Let's circle back and focus just on those dual mobility systems. You explained the basic idea, but how exactly do they work?
Okay, so they have 2 places where movement happens. 2 articulations.
Right.
The first is between the small femoral head and the inside of the polyethylene, the PE liner. Standard articulation, basically.
Okay.
The second articulation is between the outside of that PE liner and the inside of the metal acetabular shell.
So the PE liner itself can move within the cup.
Exactly. It's sometimes called an impingement device because the hip has to move far enough to cause impingement between the neck and the inner PE liner before the larger outer articulation between the PE and the metal shell even starts to move.
Ah, so that outer movement only kicks in at the extremes of motion.
Precisely. And because that outer articulation has a much larger diameter, it dramatically increases the range of motion before impingement occurs, boosting the primary arc range, the jump distance, the effective head-neck ratio, more stability.
Clever design.
Hmm.
But if we connect this to the bigger picture, does this unique design bring unique problems?
It does. There's a specific complication unique to dual mobility hips called intraprosthetic dislocation, or IPD.
Intraprosthetic, meaning dislocation within the implant itself.
Correct. It's where the small interfemoral head dislocates from the mobile PE liner, even though the PE liner might still be located inside the metal shell.
How would you spot that?
There are a couple of signs on X-ray. You might see the metal femoral head sitting eccentrically off-center within the metal cup shadow because it's now directly contacting the cup instead of the liner. And there's something called the bubble sign. Even if the head looks like it's back inside the liner, you might see the subtle radiolucent line indicating the liner itself isn't properly seated in the shell.
Why is catching that so important?
Because if it's not diagnosed, that metal femoral head articulating directly against the polished metal inner surface of the acetabular shell, that's going to cause rapid wear of the metal shell. Bad news.
What causes IPD?
Usually classified into types. Type 1 is wear of the little rim on the PE liner that's supposed to hold the head in can happen over time. Type 2 is when something physically blocks the outer articulation, like heterotopic ossification, forcing all the stress onto the inner one until it fails. Type 3 is related to loosening of the main components.
Imaging.
CT scan is really helpful here. It can show things like HO that might be blocking motion, and it's essential for planning a revision.
And management. Can you pop it back in like a normal dislocation?
No, IPD cannot be treated with closed reduction. The PE liner is out of place or damaged. It requires surgical revision, specifically replacing at least the PE component. And of course, you have to make sure the main implants are positioned correctly during that revision to prevent it happening again.
Okay, so wrapping up this deep dive, what does this all mean for you, the orthopedic resident hitting the books? We've gone through a lot. Ideal positioning, risk factors, acute management, the complexities of recurrent dislocation, and these really specific details about dual mobility, including IPD. This information, drawn from those excellent Ortho Made Simple notes at mokyingren.sg, is gold for your exams and, more importantly, for your clinical practice down the line. Definitely review these concepts. Think about the why, not just the what. Understand the biomechanics, the implant designs, the potential pitfalls.
Absolutely. That critical thinking, that attention to detail, that's what separates good from great, both in exams and in patient care. As you continue on your journey, really strive for excellence. Remember the wisdom in actively seeking out what is good and beneficial for your patients, for your skills. Keep learning, keep questioning. And on that note, perhaps a final thought to reflect on from Proverbs 11.27. Whoever diligently seeks good seeks favor, but evil comes to him who searches for it. Keep seeking the good. All the best with your preparations.